From the American Academy of Ophthalmology, this is Experts in Sight, practical conversations with experts across the spectrum of ophthalmology. Your host for today's episode is Dr. Amanda Redfern, a comprehensive and neuro-ophthalmologist at the Casey Eye Institute in Portland, Oregon.
Hi, and welcome back to another episode of Experts in Sight, the official podcast of the American Academy of Ophthalmology. I'm your host, Amanda Redfern, and I'm really excited to talk to you about this burgeoning field in ophthalmology, that of the Ophthalmic Hospitalists. Joining me today are the co-founders of the Ophthalmic Hospitalist Interest Group, otherwise known as OHIG. In alphabetical order, we have Dr. Maggie Hymowitz, Associate Professor of Ophthalmology at the Zucker School of Medicine at Hofstra Northwell, and Dr. Donna Kim, Associate Professor of Ophthalmology at the Casey Eye Institute at OHSU. Welcome.
Thanks for the invite.
Thank you for having us.
So glad you're here. So because this is a newer field in ophthalmology that not all of our listeners are aware of, I'd like to start just asking the very basic question. Maggie, what is an ophthalmic hospitalist?
So an ophthalmic hospitalist is an ophthalmologist who primarily works in the emergency room in the inpatient settings, seeing patients who have eye complaints, both urgent and emergent, primarily hospital-based.
Since this was not really a recognized field at the time that you both started, how did you fall into these roles?
So that's a great question. I am glaucoma fellowship trained, but after I finished fellowship, I entered into the academic setting and happened to work in one of the eye emergency rooms in Philadelphia at Wills. And kind of just found this little niche of emergency based ophthalmology. I was fortunate to both work in the Wills Eye Emergency Room as well as the eye emergency room at Mass Eye and Ear. And so it was kind of just a niche that I found that I really enjoyed. Seeing urgent eye cases, working with residents, medical students, teaching. It's a very dynamic, exciting environment to work in that I really enjoyed.
And Donna?
Yeah, I feel like many good things in life, we stumbled upon the opportunity by chance. And after residency, I was slotted to work at our comprehensive outpatient clinic. And I remember the bustling of conversations going on, and to be honest, of complaints from our faculty about having to staff inpatient consults and the residents lamenting late hours waiting to staff and patients unhappy about being redilated due to lack of attending availability. And I just kind of listened all around, and I was talking with our chairman, and I said, I feel like consults really wouldn't be so bad if it were the only thing you had to do. And I think it's sort of these competing obligations that made it less desirable. So I always enjoyed internal medicine. I like being in the hospital, and I spoke with my chairman about an idea for a potential new dedicated hospitalist position. And I think he was shocked that I was even proposing this idea, but delighted as well and willing to try something new with me. And so now I've been a hospitalist here at Casey for the last 12 years. And I really honestly can say I feel like I have the best job in my department.
That's great to hear. So that's how it started. How has it evolved over the years for you?
It's great. I used to be the one-person show, and now slowly and steadily we're accruing more faculty and more fellows to kind of help with consults. But I feel like we really developed it into a service. I feel like we have a great relationship with other departments in the hospital. We've designed a consult curriculum for our residents who are taking call. And I don't know, I think it's actually become a rotation that residents look forward to doing, which may have not always been the case in the past. And I think it's been equally rewarding for me to teach the residents and also just see a lot of patients with very interesting, complex diseases.
Yeah. I remember my consult rotation being just super grueling. And having a consistent consult attending made a huge difference for me. And I think for the residents that I've seen who have it, and the residents who don't have it, I think a lot of their complaints would actually be addressed by having someone who could support them like that. So why and when should a hospital or healthcare system consider starting an ophthalmic hospitalist service, Donna?
Honestly, I think it could work for a lot of places that are struggling to provide reliable consult coverage. So whether it be attending staffing for the ER or inpatient setting, I think it's very difficult to pull a lot of different people who have other competing outpatient obligations or surgeries that they're having to do. And this really protects people to do, everyone to do what they like to do, whether it be the outpatient sector or inpatient sector. And there are a lot of programs now looking at ophthalmic hospitalist models to really support their department in terms of dividing up the labor that in an efficient and effective way. And so a lot of places are now placing positions for open ophthalmic hospitalist positions that are dedicated for inpatient emergency room-based care. And I think that's been an exciting thing to see. And I really do feel like it's the future of consults because it's a need that's just not going to go away. And so this is a way, I think, to do it sustainably and actually have it be professionally rewarding for people who are staffing or evaluating hospital-based patients.
Yeah, I definitely like to talk about this as the future of ophthalmology. But before we get there, Maggie, what does a typical day or week really look like for you?
So typically our mornings start before 8 a.m. I speak to our whoever the second year consult resident is doing the rotation at the time. They rotate every 3 months. So I get a new resident every 3 months. And we usually run our list for the morning. The list for the day. We do cover a number of hospitals. We're a very large health system in New York. We cover actually 4 hospitals every day.
Oh my gosh.
Yeah, we cover level 1 trauma center. We cover a children's hospital. We cover 2 level 1 trauma centers and a community hospital. And so we're very busy. So we need to stay organized and be efficient in our care. So we usually run our list in the morning of all the patients and updates from overnight, the patients that have been admitted overnight, and we go over any sort of updates and make a plan for the day of the patients that we're going to see. We even have to specify kind of which hospital we're going to start at based on the acuity of the patients at each hospital. And then typically the resident will go in and kind of get the patient started, and then I follow shortly thereafter. And we'll go through our day, seeing the follow-up patients we need to see, patients from overnight, new consults that come in. And I see patients in the hospital with the resident 4 days a week. It's really great, the continuity of care. The resident appreciates it. The primary teams appreciate it. The patients appreciate it. It's just really, I can't imagine really providing the quality of care that we do in any other way, because these patients are acute. They need to be followed. Some of them need to be followed closely. And it's just a great experience, for everyone. And I love working with residents. We're attached at the hip for 3 months at a time. So we really get to know each other. And a lot of learning goes on, a lot of observing, a lot of teaching. So that's pretty much our day. And then at the end of the day, we run the list again. So we kind of close everything out, make sure that we know the plan for each of the patients, and then kind of set our plan for what's going to happen the next day.
So you're actually driving around to all these different hospitals that you serve.
So 2 of the hospitals are attached, so that we don't have to drive to. But yes, the third hospital we do drive to. It's about a 10-15-minute drive. The 4th hospital we cover is a community hospital that is not quite as busy. So we don't go there every day. But the other 3 hospitals we do go to. They're very busy.
Gotcha. Donna, so when I think about how surgery might tie into the role, obviously ruptured globe repairs come into mind. Do these surgeries fall under the umbrella of ophthalmic hospitalists or not necessarily?
Yeah, it's a great question. I think probably every departmental chair in the United States is wondering how best to answer this question. Up until really the last or first 10 years of me doing the job, I used to cover ruptured globes as well during the day. I actually really enjoy doing those surgeries with the residents, but our volume has increased, and I just found that it was difficult to be available for the hospital in addition to doing all the surgeries as well. And so in the past year or two, we've actually divided the consult service into an inpatient or ER based, and then there's a surgical trauma service that covers the ruptured globes. These are typically staffed by another surgical attending that rotates by the week, and they have their afternoons blocked to do ruptured globe repairs with our consult resident. And that actually works really well because they can be done for the most part during regular business hours. It also allows the consults to still be covered by another person rather than everything on hold while the ruptured globes are going, which can easily last 3 to 4 hours depending on the case. And so I think that the pain of having to do ruptured globes and having a bunch of consults waiting for you at the end of the day and having to redilate everyone is just not a very sustainable model. And so this has actually worked really well. But I know of other hospitalists that do globe repairs and consults, and it works really well for them. So I think it just depends on your setup, your volume, what you want to do, what's sustainable for you as well. And so those are some questions that everyone will just have to ask themselves. But I think the job is really nice because it's variable, and you can figure out what works for you and your department.
It's really nice that you can shape that surgical role however you like it. And that kind of leads me to my next question. What is it that you like most about what you do, and what do you like least about what you do?
Yeah, I think that the best thing I love about it are just the patients that I see in the hospital. They're complex, they have rare diseases, they have severe diseases. I love multidisciplinary care, so I have really good relationships with other services in the hospital that we work together to take care of patients. But the resident teaching is a huge part of that. Maggie has kind of gone into, I feel like our residents are essentially our other children, and we get to know them very well. And in addition to kind of clinical teaching, we just can see a lot in terms of their professionalism. I think you learn a lot by just seeing how a resident interacts with a patient at bedside who's dealing with a cancer diagnosis or something that's vision or life threatening. And it's been a really good opportunity for me to kind of learn from them, work together, how to think about how best to care for these patients in these really critical settings. But, from a logistical perspective, I hate clinic. I love not being 8 to 5 every day. I feel like I can linger with patients and their families when they're needed. I'm not slotted into a 10 to 15 minute slot that I just have to move on, even though things are left unsaid. But I can make time for spontaneous teaching. We have iPad rounds and things like that when we're waiting for people to dilate. I even sort of had some flexibility with the schedule to incorporate a clinical ethics fellowship, which I did, and that's really complemented my work well. So I feel like that would have been maybe hard where I was in a kind of structured clinic setting where I didn't have a lot of time or flexibility to also pursue these other interests. But things that I don't like about the job, there's no perfect job for sure. And so things that I think are maybe less desirable is that the days are unpredictable. So some days are just crazy busy, and it's the inherent nature of this job. And some days are going to be slower. But I feel like for the most part, every day you're going to see something that's always interesting. I think the COVID pandemic was another thing for both Maggie and I to kind of think about in terms of just navigating our own personal risks of seeing patients at the hospital during the COVID pandemic, particularly during the lockdown period and before we had access to vaccines, and we were donning and doffing crazy PPE on our indirects. So it's just,
Oh my gosh,
it was the
yeah.
nature of just this work. And then we would talk frequently about how we could best see patients safely for ourselves as well. And it's just an aspect of the job that I think may be a little bit different than the outpatient setting, but I think we've navigated it well and found a good balance in terms of, yeah, how to navigate risks, but take good care of patients.
I can see how that would have been a crazy time for you guys. Maggie, do you have anything to add about what you love or don't love about the role?
Yeah, so I agree with Donna on pretty much all of her points. I think the complexity of the cases and like each patient really is a mystery. When we get a dry eye patient, we're like, yes, we got a dry eye patient, because all of these patients, you just wonder where they come from. They're all so interesting and complex. And it's just amazing after you kind of figure out what's going on, to kind of share that experience with the resident, each and every one of them. And I say at the end of, the day, I'm like, wow, you really saw a lot of pathology today and you really learned a lot. And they don't necessarily realize that because, they're still just learning. But I really enjoy that aspect of it, and really teaching the residents that, in the hospital, you really need to know everything about the patient. You need to know their age, you need to know their gender, you need to know all of their medical problems, because chances are, and why they're admitted, because chances are why they're admitted, whatever they're complaining about with the eyes is going to be related to it. So I think it's just such a great environment for teaching, and for the residents to learn and to see the patients with them and share ideas, look up things together. It's definitely an experience that you can't have in the outpatient setting. And I will completely agree with Donna that I really like to take time with patients. I really don't like to rush from patient to patient. And so being able to take the time to see the patient, talk to them, answer their questions, and just work with the resident. I really enjoy that kind of flexibility, and that feels so confined into a little time slot. And I really have to say, I really have enjoyed becoming both colleagues and friends with a lot of specialists that are not ophthalmologists in the hospital. I have to say, I can't believe, I feel like I have this huge network now of physicians that are not ophthalmologists that I can turn to, and they turn to us, with questions and providing interdisciplinary care. And in terms of the challenges, I agree with Donna. The unpredictability of the job can sometimes be challenging, and certainly, we're still wearing, at least I'm still wearing the whole shebang in the hospital. I wear an N95 mask. I wear eye protection. I wear everything. So I've become obviously more used to it now because it's been a couple of years, but that still poses a challenge at times, because it's just not the most comfortable way to walk around the hospital and see patients.
Hopefully that's going to get better and it's not a permanent thing.
Yeah, but it's just amazing how, I don't know, at least here in New York, it's just these waves, these up and downs, and then monkeypox. And, it's like you kind of never know what you're going to get. So I just stay consistent with what I wear.
I guess you are the most prepared in this field for the next pandemic, because you're like, you see it all. And you're exposed to it all, for better or for worse.
Exactly.
So switching gears a little bit, I think a big question that comes up, this is very different from clinic-based medicine. So how does one get compensated? Are ophthalmic hospitalists salaried or RVU-based, or how does that work, Maggie?
Yeah, so I am salaried, and I think it really is the only way that makes the most sense for compensation, because there's so little that's in our control. We don't have control of the volume. We don't have control of the payer mix. We don't have control of the number of times we see patients. There are so many things that are out of our control that may be more in control in the outpatient setting. And so for that reason, I'm salaried.
Gotcha. So kind of a funny story for you. Also switching gears a little bit. When I finished my neuro fellowship, I was actually specifically looking to work in the Portland area, and I wasn't sure I was going to find any openings in neuro. And my backup plan was actually to go knocking on hospital doors and asking if they would like a hospitalist. I vaguely knew that something like this existed because I knew of Donna Kim at the time. So I was like, well, maybe I'll try that. But that was actually not a really well thought out plan. I really didn't have much of a model to go off of outside of the academic center setting. So I posed this question to the two of you. Are there independent or private practice ophthalmic hospitalists? And if so, how on earth does that work?
Yeah, we actually had a course at the Academy meeting and Craig Sis is the person who spoke from this perspective about being a practicing ophthalmic hospitalist from the private practice sector. He's fully independent. He is oculoplastics trained and goes and is contracted with various hospitals to see consults. We have another person in our Ophthalmic Hospitalist interest group who is similarly a private practice model. From what I can hear from them, we've learned a lot because it's different than the academic setting, but I think it's been really rewarding for them to sort of really be in control of pretty much every aspect of their schedules and clinic and whatnot. I think some of the hurdles they've had to figure out is how to manage some of the follow-ups and whether or not to rent clinic space to handle some of those. But I think logistically speaking, they've been creative about it. And I think it's been helpful that Craig has an oculoplastics background, so he's been very savvy about being comfortable managing globes and traumas and eyelid lacs and everything else that comes in. But yeah, we've actually learned a lot from him, and it's definitely not a model that's limited to the academic setting.
That would be super handy. Are there other fellowships that you think go nicely with this, or not necessarily? Like any background, all backgrounds welcome.
So Craig is actually a director of this new ophthalmic trauma fellowship, and that's been something that he has been sharing that can partner well with people who are wanting to focus on hospital-based care. But I have a lot of colleagues in dermatology and psychiatry who consider themselves dermatology hospitalists and whatnot, and they have dedicated fellowships in those other subspecialty areas for hospitalist work. And you would think of
Really?
dermatology. Yeah, dermatology is we traditionally think of it as outpatient, like
Yeah.
opto, but I have a lot of friends who are dermatology hospitalists, and there are dermatology hospitalist fellowships they've done to kind of help specialize in that. We actually have a few dermatology hospitalists here at OHSU as well. I work with them a lot, but they really enjoy their work. I've learned a lot from them in terms of building a group of hospitalists that Maggie and I now enjoy as the Ophthalmic Hospitalist Interest Group. But there are definitely other places doing it. And in ophthalmology, I feel like it could also be a great place of growth. Teresa Long is a member of the Ophthalmic Hospice Interest Group, and she was a resident and then fellow at the Moran Eye Center in Utah and crafted an anterior segment fellowship with a component of ophthalmic hospitalists. And she's now stayed on faculty there as a combined role and continuing to be an ophthalmic hospitalist. So she was really creative. I think she really liked her fellowship. She also did some international work as well with the fellowship. So I think it's, again, flexible, and I think there's a lot of fun you could have with designing a fellowship like that.
So do you foresee this as maybe one day a fellowship match kind of situation where this is becomes an official pathway within ophthalmology that people can go through the traditional fellowship match?
I think that'd be really exciting. I think it always takes a lot of work to set something like that up. But I think there are a lot of informal fellowships that happen all the time in terms of genetics or uveitis and whatnot. And I feel like this is a particular field that lends well to people who have an interest in it and want to be creative and maybe want to craft a fellowship that matches what they want to do and may not necessarily
Hmm.
include or not include surgery, for example. So I think the flexibility would be nice. I think it'd be wonderful to have a fellowship someday. I'm not sure that'll be around the corner as in tomorrow, but I think there are already people who are crafting fellowship that incorporate ophthalmic hospitalist work or consults, and they have really enjoyed it.
So the ophthalmic hospital movement is definitely gaining momentum at this time, especially just based on what we're talking about here. Why do you think it is that now is the time that this is becoming a much bigger thing?
Well, I think that since there's so few of us around the country and we've actually found each other, many voices are much louder than one. And so I think that now that we're finding each other and we're collaborating and sharing ideas, and certainly the Academy supporting us tremendously to give us recognition and more definition in terms of our role, because patients with eye problems in the hospital are never going away, right? And it's an
No, never.
ACGME requirement for residents to see patients in the inpatient setting. And, most, if not all, residents have a consult rotation. So it's really kind of just giving more definition to to the role, and really just improving the structure of it and the quality of it. So I think just us finding each other, and it's amazing that we found each other during COVID, but really, really finding each other and coming together and kind of just getting the word out there about it, and especially with the Academy's support and recognition.
Anything to add, Donna?
No, I think that says it all. I think for a long time I was the only person crazy enough to do this work. And then I met Maggie and I was amazed to find someone, and we started talking about creating a group and finding others. And now we have this ophthalmic interest group, a hospitalist interest group that has really over 100 members, and not everybody is, obviously seeing consults or fully inpatient based, but it's been a thriving group and fun, and I think honest too about what makes the job great and what makes it hard, and sharing ideas about how to make it better as well, and fun for residents. So it's been a really, I think from a job that went feeling fairly isolating, to something that's actually been a wonderful sense of community with others, and collaborating with multiple different departments across the country on projects and research and ideas for resident teaching. So that's just been really fun to grow in that way.
Any advice for aspiring ophthalmic hospitalists?
Many people are hiring. There are a lot of open positions, and you can actually find them on the AUPO website. There are a few posted on the Academy website. If you join the OHIG AAO online community, people have posted things there as well, or our OHIG webpage, we have job openings. But I think there's definitely demand for it. Maggie and I both agree it's a wonderful job, but it's a job that must be set up for success. So it must have a sustainable schedule. You must have departmental or your practice support. You need to have adequate payment. And I agree with Maggie. I don't see how this job could work unless it's salary based. But that being said, I think your salary funding can come from your department, but it really also can come from the hospital as well, because we're providing a service for the hospital that many of them are level 1 trauma centers and require ophthalmology coverage to meet that designation. So for some positions, they actually get some of their funding from the hospital as well. And so these are all things that you should just look into. Again, the flexibility of it and kind of what a department or division needs is important to look at as well. But I think I love it because it's creative, and I think don't be afraid of trying something new, and that's been working really well for me.
Yeah, I agree with Donna. It's not one ophthalmic hospitalist model fits all. I think it's really what the department needs are, what the hospital needs are, what your interests are, and really kind of being we're out of the box. So being an out of the box thinker of kind of what interests you if you really enjoy working in the hospital, but also have an interest in neuro-ophthalmology or oculoplastics or another specialty, in terms of kind of how to create a position that you find exciting and are interested in, and what would work with the department and the health system. I think that's one of the things that's really the best about this job, because you can create it as to what interests you most.
And one thing that was brought up on our panel course that I thought was a really good point is that this is a great job for someone right after residency or very savvy and familiar with doing inpatient and ER consults and staffing if that's of interest to them. But I think it's a great position for someone who wants a change in their career, whether they're mid-career, maybe heading towards retirement and wanting to have less clinic, but still be an environment where they teach residents. And so I think that's what's nice about it. You could be freshly out of residency versus later in your career, and it could be a really great fit depending on if you're just wanting a change from maybe what you do or what's considered traditional.
You're always planting that seed, huh, Donna?
I
am. Before we go, Maggie, can you talk a little bit about the OHIG resources that are available for people online and through the Academy?
Sure. So we have a website, www.ohig.org, that has a tremendous amount of information. It does have a list of all of our members. It has a list of both our past and future events. It also has our monthly newsletter that we create every month. It's Usually there's a hot topic that's the theme of each newsletter. We include up-to-date articles. We include an interesting consult round case. We include fun pearls. We spotlight attending such as Amanda. We what else do we do, Donna? We really try to provide kind of really up-to-date information. We do surveys, we ask questions to our members to kind of survey the group. I mean, one survey that was incredibly helpful was, what PPE do you wear in the hospital during COVID? This was one of our, very early newsletters when we actually first started and didn't really know what we were doing in the hospital.
I really love your guys' surveys, by the way. Just being as part of the group and seeing how everybody responds to all different scenarios, or how do you deal with these different consult situations, or whether you're a hospitalist or not. Like, a lot of us will cover consults, just part of your academic affiliation or your role. And so just seeing, like, how do you deal with this scenario? What does your hospital do? It's really fun to see the variety, because I think we get so locked into doing things one way.
Yeah, and I think some of the pain of consult is having to sort of reinvent the wheel. So every time a new person comes onto service, or, oh, I don't know, where's the fundus camera for NAT, or, oh, how do we do this or that? But it's just been a nice resource for people say, hey, I figured out a good idea for that, and this is what it is, and someone can go off running with that without having to reinvent the wheel every time you come across the same problem at a different place.
Okay, well, thank you so much. Those are really awesome resources, and thank you so much for joining me today. This has been awesome, and I've really enjoyed hearing it from you two, how you started in this field and where it might be going.
Thanks so much, Amanda.
Thank you for having us.